This is Judith with Illinois Partners. Welcome to our Monday afternoon call-in meeting. This webinar is being targeted to the CEOs, presidents, executive directors of the Human Service community-based provider network, and will be made available to you after today's webinar. So again, let me thank you. Before I make the introductions of Kathy and Andrea, let me just do a couple of housekeeping items, if I might. So if you could please grab a pen and paper. I'm going to give you a phone number as well as an email address in the event that you have technical difficulties during this webinar. Please call 312-368-1154. Again, that's 312-368-1154. And the email is rachelgiellau@povertylaw.org. We'd like this webinar to be interactive, and the presenters truly welcome your questions. So can I please encourage you, as the presentation is beginning and going forward, please send your questions in as you think of them. And at the end, we will have time to answer questions. So again, please help us be interactive. Please use the question features on the control panel. After the webinar, you'll receive an email with the link to the webinar resource page where you can find the presentations and other resources, and we will also make the webinar available through the illinoispartners.org website. So now, if I might, I'd like to introduce Kathy Chan to begin the webinar.
Great. Thank you, Judith. On behalf of the Illinois Maternal and Child Health Coalition, thank you for participating in today's webinar. My name is Kathy Chan, and I serve as the Associate Director and Director of Policy and Advocacy with the Illinois Maternal and Child Health Coalition. You may have experience working with us on women and children's health policy issues or through one of the projects listed on this slide. Please feel free to visit our website or contact me afterwards to learn more about any of our work.
Good afternoon. My name is Andrea Kovach, and I'm a staff attorney at the Sargent Shriver National Center on Poverty Law. I am also very pleased to present to you today. The Shriver Center provides state and national leadership on health policy issues, and we encourage you to visit our website and contact us.
So we're going to use the next 40 to 45 minutes to provide you with a big picture overview of the Affordable Care Act and offer specific information about insurance market reforms, the changes to Medicaid that will take place in 2014, the competitive health insurance marketplace, also referred to as the exchange, the small business tax credits, expected changes to the healthcare delivery system, and finally, we'll offer some helpful resources and then open it up to questions from you. So this next section is meant to provide some basic information about the Affordable Care Act, so many of you may already be familiar with some of this, especially if you have participated in past presentations with one of our organizations. On March 23rd of 2010, President Obama signed the Patient Protection and Affordable Care Act into law. 7 days later, he signed the Healthcare and Education Affordability Act of 2010, which made some changes to the first law. Together, these two laws are commonly referred to as the Affordable Care Act, or the ACA. These laws already have and will result in major changes in the way our country's health insurance and healthcare systems work, as well as provide affordable health insurance to millions more people. So health reform is a really, really big deal. The ACA will eventually provide health insurance coverage for 32 million more people who lack coverage today. The goal is to provide families with the security and peace of mind that comes from knowing that when they need their health insurance, it's going to be there for them. According to recent data, approximately 12%, or just over 1.5 million Illinois residents, are uninsured. As a result of the ACA, this number is expected to decrease from 12% uninsured in 2011 to 7% in 2020. The Congressional Budget Office, the nonpartisan scorekeeper of spending in Congress, estimated that health reform will reduce the federal deficit by $124 billion between 2010 to 2020, and $1.2 trillion more in the following decade. All of this is while providing health coverage to millions more people. So this next slide talks about grandfathered plans. Some of you may remember that during the ACA debate and discussion, when President Obama repeatedly stated that if you like your insurance, you can keep it. Well, this refers to which plans are affected by certain insurance reforms and regulations. Employer plans that existed prior to March 23rd of 2010, and remember that was the date that the ACA was signed into law, essentially remain the same, except that the insurers will now have to abide by some of the new consumer protections that we will talk about. These are often referred to as grandfathered plans. However, health insurance plans created after March 23rd of 2010 must comply with all the new benefit provisions and consumer protections. Plans would lose their grandfather status if they choose to significantly cut benefits or increase out-of-pocket spending for consumers. Next, we're going to talk about some of these insurance market reforms that will help make coverage more accessible to more people by ensuring greater fairness and transparency in the private insurance marketplace. So effective January 1st of 2014, the practice of gender rating will no longer be allowed. Gender rating is the practice commonly used by insurance companies to charge women more for coverage just because of their gender, even in situations when maternity care coverage is not included. In Illinois, this has resulted in women being charged as much as 57% more than their male counterparts for insurance in situations when all else, including age, health status, and geography, is equal. In the past, insurance companies were allowed to rescind coverage for treatment or care if an individual misrepresented his or her health status at the time of application, even if the misrepresentation was unintended. Once an individual began to access his or her insurance policy for covered treatment, the insurance company would search for an error in the application. If an error was found, the company could retroactively cancel the policy and then terminate coverage. However, as of September 23rd of 2010, insurers must prove, quote unquote, an intent to deceive in the misrepresentation on the application. This means that insurance companies must prove that the individual knowingly misrepresented his or her health status during the application process to be able to rescind the coverage. Okay, pre-existing conditions. I think this is a term that many of us are familiar with. So under current law, under current Illinois law, an individual can be denied health insurance coverage for any reason other than race, color, religion, or national origin. With national health insurance reform through the ACA, Illinois' current law is preempted, and individuals and families will not be denied health insurance simply because of a current or prior illness or the prospect of an illness in the future. As you can see, it's estimated that over 200,000 Illinois residents have a pre-existing condition. These conditions can range from asthma to cancer, but can also include things like being pregnant or having had a cesarean section. So for children under the age of 19, this new protection around pre-existing conditions applies for plan years beginning of September 2010. That means that insurers are required to cover pre-existing conditions for children. The insurers are required to cover children with pre-existing conditions as of that date. For everyone else, this protection is going to be in place by January 1st of 2014. After 2014, insurers will no longer be able to charge higher premiums or deny coverage altogether based on a pre-existing condition. However, remember that because some plans are grandfathered, the restrictions on pre-existing conditions only applies to new plans and group grandfathered plans, but not to grandfathered individual plans. So what are the health insurance options available today if you have a pre-existing condition? For individuals who have been denied private insurance and who have been uninsured for 6 months or longer, they may be eligible for coverage in the Illinois Preexisting Condition Plan, or IPXP. IPXP is Illinois' program in response to the $5 billion of federal funding that was given to all of the states to create what are referred to as temporary high-risk pools. These are pools that will cover people who have pre-existing conditions and who have been uninsured for at least 6 months. This temporary high-risk pool is considered a bridge program until 2014, when health reform will require insurance to cover adults with pre-existing conditions. Requirements to participate in IPXP are listed on the following slide. So the requirements include being a U.S. citizen, a national or legal resident, being uninsured for at least 6 months, having a pre-existing condition, and having the ability to pay for the premiums and out-of-pocket costs. So the premiums that are charged by the IPXP program must be equal to or less than those charged for similar coverage in Illinois, and male and female enrollees must be charged the same rate. So for example, under IPXP, a 35-year-old non-smoker living in Cook County would pay around $239 a month for premiums with a $2,000 deductible. IPXP is administered through the Illinois Department of Insurance, and enrollment began in fall of 2010. For more information, you can contact the department's toll-free number at 877-527-9431, or you can visit the website that's listed on this slide. The ACA also imposes what's called medical loss ratio on insurers, so that Americans receive value for the premium dollars that they paid. Beginning this year in 2011, the law requires insurance companies in the individual and small group markets to spend at least 80% of the money that they collect from premium dollars on medical care and quality improvement activities. Insurance companies in the large group market must spend at least 85% of premium dollars on medical care and quality improvement activities. And this is in contrast to spending it on things like administrative costs or profits or marketing. Insurance companies that don't meet the medical loss ratio standard are going to be required to provide rebates to their customers. Insurers will be required to make the first round of rebates to consumers in 2012, and rebates must be paid by August 1st of each year. Enrollees who are owed a rebate will see a reduction in their premiums, receive a rebate check, or if the enrollee paid by credit card or debit card, a lump sum reimbursement to the same account that the enrollee used to pay the premiums. One way that the Affordable Care Act encourages the use of preventive care services to get and keep people healthy is by making certain preventive care services available without a copay or cost sharing to that plan participant. So new plans issued on or after September 23rd of 2010 must offer free preventive health services when they're accessed through an in-network provider. These services include recommended screenings, diagnostic tests, annual visits, and vaccinations, and some of these services may depend on a person's age. So to take a look at the full list of preventative services included in this requirement, check out the website that's listed on this slide. So we're going to switch gears a little bit, and in this section I'm going to cover changes to Medicaid that will have a dramatic impact on how many more low-income Illinois residents will access health coverage. As many of you already know, in order to presently qualify for Medicaid in Illinois, you must be part of a category such as being a child, a parent with a child in the household, a pregnant woman, or aged, blind, or disabled. Adults who don't fall into one of these categories are not eligible for Illinois Medicaid, even if they are low income. But starting in 2014, this will change. So on January 1st of 2014, the ACA will expand Medicaid to allow for everyone under the age of 65 with household incomes up to 133% of the poverty level to be eligible for Medicaid. Individuals will still need to meet citizenship and immigration requirements covered in a later slide. Approximately 700,000 new people are estimated to be eligible for Medicaid in 2014. Initially, the federal government will pay 100% of the cost for those who are newly eligible for Medicaid. After 2016, the matching rate will begin to steadily decline and will level out at 90% in 2020 and for future years, which is still well above the current matching rate of 50% that we receive for Medicaid right now. This slide shows the income eligibility guidelines for the newly eligible group of Medicaid enrollees with household incomes less than 133% of the poverty level. Therefore, a single adult living alone would need to have an income less than $14,483 on an annual basis to be eligible for Medicaid under this new expansion. So when it comes to simplifying eligibility for Medicaid, the ACA adopts an important philosophy, which is to remove burdensome requirements that have often been barriers to coverage of people trying to access Medicaid in the past. As a result, Medicaid is going to use a new income standard referred to as Modified Adjusted Gross Income, or MAGI, and this will be used to determine eligibility for all subsidized health programs, including Medicaid and the premium tax credits, which Andrea is going to talk about later. No asset test will be applied in Medicaid for individuals whose income is calculated using modified gross income, MAGI, including parents and other non-elderly adults as well as children. A no wrong door approach is going to be applied, which means that there's going to be a single application form for all health programs, that applications can be made online, in person, by mail, or by phone, that applicants will be screened and enrolled in appropriate coverage options regardless of their entry point, and no unnecessary information should be required or requested from the applicant. The ACA sets forward expectations to have a single web portal for enrollment with real-time eligibility determinations using data that is verified electronically. This will allow for the use of paperless verifications by cross-matching information in other state and federal databases, which can allow for a more efficient use of administrative resources. To help make states make necessary systems upgrades, the federal government is providing significant financial support for these new IT systems. So when it comes to the newly eligible populations for Medicaid, again, a review of those who are newly eligible will include those persons between 18 and 65 years old, is at or below 133% of the poverty level, and it's important to also note that there will be a 5% income disregard. So you may hear 133% or 138%. The 138 takes into account that 5% income disregard. The person has to be a U.S. citizen or legal resident living here for at least 5 years, and they cannot be eligible, they would not be, in order to be eligible for the Medicaid starting in 2014, they would not be eligible for Medicaid prior to December 1st of 2009. That is a condition of them qualifying for the new Medicaid program. So the subpopulations that are going to be the ones that will benefit the most from the Medicaid expansion will include those childless adults. So those are defined as adults who are either single or living as a couple in a household without any children, young adults aged 19 to 25, older populations that are not yet eligible for Medicare, homeless individuals, minority populations, and also parents. I'm going to turn it over to Andrea, who's going to talk about the exchange. So the Affordable Care Act also includes provisions for states to set up a competitive health insurance marketplace or exchange. The idea for the exchange is to help a slice of the public for whom insurance traditionally has been especially expensive, and that's people who have been trying to buy coverage on their own or as part of a small employer. The goal of the exchanges is to make it easier for these folks to compare health plans while at the same time creating pools of customers large enough to slow rising prices. So starting in 2014, in one location, using one application, all insurance plans, including Medicaid, as Kathy described, will be presented in a clear, user-friendly format that allows consumers to understand plan terms and compare benefits and services across plans to be able to choose their insurance plan from one of the options listed on the exchange. Household income, family size, and citizenship information will be verified through data matching with state and federal databases. And the applicant will input their preferences for the type of insurance plan, and then the exchange will provide the different plans and benefits that meet that criteria. Qualified health plans participating in the exchange are required to have enough providers to cover their patients. They're also required to contract with essential community providers, as well as perform well on quality measures. In Illinois, initial projections are that the Illinois Exchange will enroll 486,000 individuals in 2014 and over 1 million by 2016. The Affordable Care Act mandated that a broad package of essential health benefits equivalent to that of a typical employer plan be offered by the qualified health plans participating in the insurance exchanges. Congress then directed the Department of Health and Human Services to develop a specific list of benefits, and they in turn enlisted the Nonpartisan Institute of Medicine to recommend a process for defining this package.
Just a couple weeks ago, the Institute of Medicine recommended that HHS develop by May 1st of 2012 an initial essential health benefits package based on the general categories listed on this slide that are specified in the ACA. The package of benefits must be affordable for consumers, they said, while covering these basic healthcare necessities. HHS is going to hold a series of listening sessions to gain input on what specific benefits within these broad categories listed on the slide should be in the final benefits package. So stay tuned. The Affordable Care Act sets aside federal funding for families with household incomes of less than 400% of the poverty level to provide financial help in paying for insurance premiums. So if a lower income family makes too much to qualify for Medicaid but still cannot afford insurance, there is financial help from the federal government to help with the cost of private insurance. Applicants will learn if they qualify for this financial help when they apply for insurance on the exchange. In Illinois, it's projected that 73% of people who enroll on the exchange will be eligible for this federal assistance. And this slide shows the income eligibility guidelines for this federal financial help. A single parent with 2 kids, for instance, would need a household income of less than $74,120 in order to qualify for the financial help to use to purchase health insurance. The ACA states that an exchange must be available in each state by 2014. And if a state refuses to set up its own exchange, then the federal government will do it for them. States have a deadline of January 1st, 2013 to prove to federal health officials that they are on the path to be ready. The federal government is offering virtually a blank check to states to start building and staffing the exchange. But they have to qualify for this establishment grant, for this blank check. In order to qualify, by early winter of 2012, states need to prove to the federal government that they have decided on a certain key components of their exchange, such as the governance structure for the exchange, and how the exchange will be self-financing after 2015. So how are we doing in Illinois? In Illinois this past spring, a bill was passed and signed by the governor called the Illinois Health Benefits Exchange Law. And this law declared that Illinois, beginning October 1st, 2013, shall establish an exchange to, quote, help individuals and small employers with less than 50 employees shop for, select, and enroll in qualified, affordable private health plans that fit their needs at competitive prices, unquote. The law established a legislative study committee to conduct a study on state implementation and establishment of the Illinois exchange. This 12-member committee met 5 times during the late summer, and on September 27th, the study committee released a draft report of their findings. These findings related to the governance structure of the exchange, as well as financing the exchange after 2015 when states can no longer rely on federal dollars. With regards to governance, the committee considered 3 different models: a state agency model, a nonprofit model, and a quasi-governmental model. The committee did not choose a specific model, but the submitted oral and written testimony to the committee from advocates and interested parties seemed to choose a quasi-governmental model. The committee did not choose a financing structure for the exchange either. The Legislative Study Committee is expected to issue a final report soon. Many of the consumer advocates supported a quasi-governmental governance structure for the exchange, as well as supported a financing structure that assessed all insurers offering plans both inside and outside of the exchange. Many consumer advocates supported a strong conflict of interest policy covering those who sit on the governing board of the exchange. Such a policy would bar insurers, brokers, and agents from being voting members on the exchange governing board, and would require voting members to represent consumers, small businesses, and diverse vulnerable populations. Advocates also support that a bill be passed during this veto session so that Illinois can be on time to apply for hundreds of millions of dollars of federal funding to establish the exchange in our state. If you would like to learn more about the Illinois Legislative Study Committee, please go to the website listed on this slide. There you will find consulting reports on the current state of healthcare in Illinois and on the possible options and directions the exchange could take. You will also find the committee's draft report and comments from advocates, including the Shriver Center and Illinois Maternal. There is still time to reach out to legislators about the importance of designing a consumer-focused exchange. Next, we're going to talk about the small employer tax credits from the Affordable Care Act. The ACA helps small employers afford the cost of covering their employees. If you have fewer than 25 employees and provide health insurance, you may qualify for the small business tax credit of up to 35% or up to 25% for nonprofits to offset the cost of your insurance. This credit will increase in 2014 to 50% or 35% for nonprofits. In order for an employer to qualify, it must cover at least 50% of the cost of health care coverage. The employer must have less than the equivalent of 25 full-time workers. So for example, an employer with fewer than 50 half-time workers may still be eligible. And the employer must pay average annual wages below $50,000. Again, both for-profit and nonprofit organizations qualify. Small businesses pay on average 18% more than large businesses for the same coverage, and health insurance premiums have gone up 3 times faster than wages in the last 10 years. This tax credit can help bring those costs down and make coverage more affordable. 194,000 small for-profit and nonprofit employers in Illinois could qualify for this small employer tax credit, making it easier for them to provide coverage to their employees and make premiums more affordable. A recent Kaiser study showed that 46% more small employers, those with 10 or fewer employees, were now offering health insurance to their workers because of this tax credit. The website listed on this slide allows an employer to calculate whether they qualify for the credit. I wanted to briefly cover some of the changes that the ACA makes to the way health care will be delivered, as well as briefly cover how this is playing out in Illinois. This slide provides an overview of the most prominent healthcare delivery models in the ACA. The first is the fee-for-service model. This is where providers are paid a set fee for each medical service. This model is currently being used in Illinois' Medicaid program for most enrollees, as well as in the private healthcare setting. The coordinated care model is where providers are paid upfront to coordinate and ensure the full spectrum of services a patient requires. The ACA includes many provisions that reward providers for using a coordinated care model. And it established a federal coordinated health care office within CMS to more effectively integrate benefits and improve coordination between state and federal governments for dual eligibles. In Illinois, the Department of Health Care and Family Services has already started to implement this model for some of its Medicaid population. And it's planning to have at least 50% of its Medicaid population enrolled in coordinated care by 2015. We're going to discuss this further in a minute. Accountable care organizations coordinate healthcare in one place, integrating primary care, specialists, hospitals, labs, etc. The providers accept joint responsibility for the quality of care and the cost of care patients receive. The ACA allows new payment arrangements for Medicare and Medicaid for health systems that qualify as ACOs. Patient-centered medical homes is a primary care healthcare setting facilitating partnerships among patients and providers. The ACA includes grants to support medical home models and policies to enhance payment for patient-centered primary care. In Illinois, just under 1.8 million enrollees were enrolled with the primary care provider Illinois Health Connect for their medical home. Consumer-operated and oriented plans, or co-ops, are nonprofit, member-owned health insurance entities offering qualified health plans based on an integrated, consumer-focused model. In a co-op, the same people who own the company are insured by the company. Cooperatives can be formed at a national, state, or local level and can include doctors, unions, hospitals, and businesses as member owners. This model is promising for certain populations such as undocumented immigrants who can't access Medicaid or buy insurance on the exchange. There is currently $3.8 billion in federal funding available to facilitate creating co-ops. Illinois' current health insurance market is highly concentrated, so co-ops could be a good addition to Illinois' market. House Bill 3236, a health benefits co-op bill, passed the House earlier this year, and the sponsors are working to build the support to pass the bill in the Senate during veto session. This bill, if enacted, would enable small employers to create their own nonprofit health insurance plans. The cooperatives would be operated and governed by representatives of the business owners and employees enrolled in the cooperative. Changes to the way healthcare is delivered have the potential to provide many benefits to enrollees, particularly for the Medicaid population. If care is delivered smartly and efficiently, it could cure access problems and promote prevention and coordination and better health outcomes. However, if care is delivered sloppily and only to save money, it could damage access, especially for chronic needs. The Shriver Center, Illinois Maternal, and many other advocates are carefully monitoring Illinois' changes to its healthcare delivery system to help ensure that care is delivered in a way that promotes good quality outcomes and increased access along with greater efficiencies. So let's delve a little deeper into how Illinois has started to change the way it delivers health care for its Medicaid population. In 2010, Illinois' Department of Health Care and Family Services started an integrated care coordination pilot program for 40,000 seniors and persons with disabilities in the Illinois Medicaid system who live in suburban Cook and McCulloch counties. HFS contracted a pay-for-performance payment model with Aetna and Centene Illini Care. This pilot moves away from the current fee-for-service delivery system and aims to bring physicians, hospitals, nursing homes, and other providers into a network connected with electronic medical records and other coordination processes. Enrollment is still being phased in, and providers are still joining the networks. Advocates are working with Aetna and Illini Care to prevent disruptions in care. Also, Medicaid reform legislation passed in December 2010, and it specifies that by 2015, at least 50% of all Medicaid enrollees will be in a risk-based or capitated coordinated system of care. The law specifically notes that Illinois Health Connect, the state's current primary care case management system, under its existing organization, does not qualify as care coordination towards this 50% goal. However, the Medicaid Advisory Committee to HFS is currently discussing what changes could be made in order for it to qualify. According to the Medicaid reform law, payment for the coordinated care program will be based on pay for performance related to health quality outcomes, the use of evidence-based practices, of primary care delivered through comprehensive medical homes, of electronic medical records, and the appropriate exchange of health information electronically. The next meeting, by the way, of the Medicaid Advisory Committee, if you would like to get involved in this discussion, is November 18th. So in the meantime, HFS has launched what they are calling their Innovations Project. This Innovations Project is designed to achieve the 50% care coordination mandate. The first phase of the Innovations Project is for providers only. And HFS has issued a solicitation for proposal, or it will be issuing a solicitation for proposals in January of 2012, with the contracts executed as soon as next summer. HFS is requiring development of a care coordination model that includes medical homes and facilitates care transitions or coordination among the various providers. These providers will include hospitals, primary care specialists, behavioral health providers, substance abuse providers, and dental providers. For the Care Coordination Project, HFS is prioritizing the senior and adults with disabilities population and individuals with mental illness and/or substance abuse disorders. Fee-for-service will be preserved for medical services as HFS works towards more pay-for-performance risk-based capitation models. In addition to the fee-for-service, the providers in their proposals to HFS must propose one of 3 different pay-for-performance or coordination models. So the first that the providers can propose to HFS is to be paid a care coordination fee, which would be based on performance and quality measures. Or that the providers can propose to HFS that they'll participate in a shared savings model. And that's where coordination can result in a portion of shared savings returning to the providers and the remaining savings going to the government. Or providers can propose in these proposals to HFS that they will engage in some other risk-based pay-for-performance model. Enrollment in the Innovations Project Care Coordination Program will be handled by client enrollment brokers, and there'll be a separate RFP for organizations that wish to become client enrollment brokers. For human service providers, there is a potential for some who are medical care providers to submit a proposal along with other providers located in the same geography under this Innovations Project. Or human service providers might want to submit a proposal to be a client enrollment broker. HFS has stated that they are very interested in proposals that involve coordinating a comprehensive network of different types of care in the community, not proposals that just involve hospitals only. Towards that end, HFS might be interested in proposals that include supportive housing providers too, since there is an arguable medically necessary case that people in transition from hospital stays will need to include some sort of medical component like nurses or a staff doctor. Human service providers might want to discuss with HFS how efficient coordination of care would involve these other non-traditional providers. In another example, if you include social workers in a full-service coordinated care network, it could very well bring down healthcare costs when they provide case management or counseling or addiction therapies, or when they prevent readmissions to hospitals or avoid the ER. HFS plans to have a public meeting this month or early next to discuss annual performance and quality goals for the Innovations Project. For more information on this project, please go to the website on your screen. Another example of care coordination in Illinois is found in the Medical Home Network. It's a new safety net accountable care organization funded by a local foundation. It's been in the planning stages for a long time, but it began to activate this summer on Chicago's south and southwest side. The network is targeting women and children enrolled in Medicaid who are at a greater risk for readmission. The network links hospitals and medical clinics through an internet portal. So here's how it would work. If a Medicaid patient from a participating clinic comes to an ER or is admitted or discharged from a hospital, the clinic will receive an alert within 24 hours with basic information about the reason for the patient visit, the diagnosis, the medications prescribed, and a short summary of the care plan. That allows the clinic to contact the patient and offer follow-up care as soon as possible. So I've listed hospital partners and clinic partners for the network on this slide. This slide shows a snapshot of the landscape of healthcare reform over the next few years. By law, HFS must report to the General Assembly starting in April 2012 on progress that it's making towards implementing the Care Coordination Program. HFS plans to start enrolling newly eligible Medicaid clients in late 2013. HFS will have to establish care coordination delivery systems prior to the fall of 2013 in order to meet the statutory mandate of having at least 50% of Medicaid enrollees enrolled by 2015. In 2014 and beyond, the state-based exchange will be operational, so individuals will be able to enroll in Medicaid or private health insurance plans. Low to moderate income families will be able to receive the federal financial help to help pay for their premiums. Most Illinoisans will be required to purchase health insurance coverage unless exempt. That's through the individual mandate. And again, at least half of Medicaid enrollees will be in care coordination by 2015. Accountable care organizations and co-ops will also be operational by in 2014 and beyond. For human service providers, payments for clients currently uninsured will come from Medicaid because remember, as Kathy said, there's going to be about 700,000 more newly eligible folks eligible for Medicaid in 2014. Or payments for clients currently uninsured may come from private insurance because so many more people will now qualify for affordable private insurance from the exchange. They'll no longer be banned from getting private insurance because of a pre-existing condition, for example. And your currently uninsured clients will hopefully have increased access to comprehensive, coordinated healthcare services. Unfortunately, a lot of questions are still up in the air about the landscape in Illinois for 2014 and beyond, but answers are continuing to come in as the ACA implementation continues to roll out.
So as you can probably tell, the ACA and healthcare reform implementation has a lot of moving parts to it, and by no means is this presentation meant to provide an exhaustive list of resources or information. So as a couple of pieces to supplement the information that we've provided you today, there are other resources that both Illinois Maternal and Shriver Center recommends for you to check out. And the first is healthcare.gov. So if you haven't already visited this website, we certainly encourage you to do so. It's a very user-friendly website that provides a lot of great information about the Affordable Care Act. Consumers can see what private insurance plans are available to them depending on their age, state, current coverage, and also health conditions. And there's also information about public programs like Medicaid and how reforms in the new law affect people, such as small business tax credits that Andrea talked about, the high-risk pools that were mentioned earlier, and the ability of young people to join or stay on their parents' health coverage plans till the age of 26. The website also includes rates, coverage exclusions, and other pricing information for private insurance. Another local resource is Illinois Health Matters, which is at www.illinoishealthmatters.org, which numerous organizations, including Illinois Maternal and the Shriver Center, contribute to. Illinois Health Matters is a one-stop shop for both consumers, providers, policymakers, and members of the media for blog entries, fact sheets, reports, and videos on the implementation of the Affordable Care Act. So thank you very much for taking the time to participate in our webinar. This is our contact information for myself and for Andrea, and we will be opening it up for questions.
If you have any questions, please submit them in the question box. And if we receive any questions after the webinar, we're happy to answer them and send you a follow-up email.
So again, just as a brief reminder, we will have a copy of the presentation available for everybody. We'll wait a minute or two here to see questions as they come in. And in advance, I'd like to thank Kathy and Andrea for an outstanding presentation that is extremely valuable and, as you could hear, a tremendously moving target that they are and continue to keep their pulse on behalf of human services. So we'll give another minute or so to see what questions come in before we close. So a question that we've just received, Andrea, Kathy, what incentives do primary care providers have to collaborate with community providers?
Well, in terms of the innovation project, there's definitely going to be a priority placed, according to HFS, on proposals where primary care providers do collaborate with community providers, as well as other providers in the community that could include hospitals, to form a comprehensive network of care if they're interested in participating in the Innovations Project. And this project is really just a first step that HFS is taking, again, to have a coordinated care model throughout the whole state. So I would say that the Innovations Project provides one very big incentive to start collaborating.
Thank you. Next question. Care coordination units should be talking with hospitals for fee to service. What revenue stream will the hospital have to pay that fee? Nancy, we will get back to you offline. We need some more clarification on your question. Next question. Will that priority to collaborate ever become a mandate? Hospitals are currently choosing to develop their own in-house networks.
Well, I don't know if I can actually answer that. That's probably a question for your discussion with HFS. I can just say that in the meetings that I've listened to that HFS has hosted regarding care coordination, they've really emphasized, again, that they're going to be looking for proposals that go beyond hospitals just having proposals with in-house networks that really, again, reach out to the other providers in the community.
And next question, is dental health included in any way in the ACA? Many dentists do not serve individuals on Medicaid. Will this improve?
So this is a great question. So as many of you know, oral health has been one of the most overlooked kind of medical fields in healthcare. However, the Affordable Care Act addresses this disparity by implementing a number of programs and benefits that will gradually improve the quality of oral health care and hopefully the capacity of oral health as well. So regarding specifically this question around Medicaid rates, there is not yet a set answer, so there's no requirement to necessarily raise the rates for the Medicaid dental payments that are currently offered to Medicaid providers in the oral health network. However, there is a national board that is looking at reimbursement rates across all of Medicaid, and oral health is represented on that board, and they're looking at the adequacy of the rates that are being paid to providers at the state levels. So I think there's more to come for that. In addition, there are a number of different provisions within the ACA that do address oral health needs, specifically for children. So when Andrea had talked about the exchange earlier, insurance plans in the exchange that are for children must include oral health care coverage. That's not required for adults, but that does address some of the needs for children who are accessing the private insurance plans in the exchange. Adults are going to be able to purchase standalone dental coverage packages through the exchange. For children, oral health services are considered preventative. So preventative pediatric oral health services are going to be one of those benefits that will be offered free of charge for persons enrolled in those insurance plans. There's also money from the ACA that's going to public education campaigns around oral health. So there's a multi-year evidence-based public education campaign to promote oral health with a focus on early childhood caries, on prevention, on oral health for pregnant women, and oral health of at-risk populations, so communities of color, low-income communities as well. There's also workforce development, and this is not necessarily exclusive to oral health, but it is exciting that oral health providers are included in the discussion of developing the workforce. So creating the National Healthcare Workforce Commission, specifically with oral health as a designated workforce issue and also as a priority. There's also new grant programs to allow for health professionals to come into the network, to come into the provider community. Also, additional stipends and loan repayments to institutions that include dental schools that provide training for individuals to serve in the National Health Service Corps, which again is broader than just dentists and dental hygienists, but to healthcare providers who serve in underserved areas.
Thank you, Kathy. Next question. I've been told there will be a tax applied to support the costs of the ACA. How will this be applied? Will employers be making deductions to employees' pay?
If you could be a little bit more specific on the tax that you're referring to, we will get back to you on that. But I'm not sure if I can answer it without knowing a little bit more about the tax you're referring to.
So Kyle, if you could just further offline do that, Andrea and Kathy will do research and let you know what kind of tax, if any, you're making reference to. If there are not any more questions, I'd like to again personally thank Kathy and Andrea for putting together today's webinar. The available information will be shared tomorrow and will be on the Illinois Partners website as well. And stay tuned. Illinois Partners will be having another call-in meeting as we get ready for veto session next week, and there will be issues that we are going to be asking our members to please be cognizant of and advocating for. So again, my sincere thanks, and thank you to Kathy and Andrea.
It was our pleasure. Thank you very much.
Thank you.